Hello, my name is Dr. Karen Horridge. This presentation is going to be about variations in child development, a structured approach to the assessment, investigation and identification of those with a learning disability. Key messages of this presentation are that each and every child and young person is unique. Careful clinical assessment and thought needs to come before any investigations. Precise identification and documentation of a child's each and every need informs proactive care planning to achieve the best possible outcomes. Identification of learning disability in childhood matters because it's only if this is given its name that we are able to reduce mortality and morbidity across lifespans by making appropriate, reasonable adjustments for inclusion and access to services. Advocacy matters to achieve the very best outcomes of all, underpinning all that we do. Diagnosis matters for families of disabled children. This is because it gives an explanation for why their child is different. It informs prognostication. It allows us doctors to give a more accurate picture of what a family is to expect moving forwards, because we can go and consult the literature about what it says about that specific condition. Diagnosis matters because it informs proactive surveillance for associated health conditions that may be known to co-occur, rather than passive monitoring of the natural history of the condition which otherwise occurs. Having the right diagnosis stops parents, particularly mothers, from blaming themselves, which they otherwise want to do. When we are assessing children and people whose development is different, we need to hold in our minds the World Health Organization's conceptual framework of disability based on the International Classification of Functioning, Disability and Health, or the ICF. In this framework, we're concerned not just with health conditions and body structure, but also with body function, with the activities that the child or young person wants to do, and their ability to participate in those everyday activities. We need to consider any environmental factors which might be both enablers and also barriers to inclusion and participation, and also personal factors that might make a particular child resilient or another child vulnerable. Steps towards achieving the best outcomes for everybody include having all universal services accessible for all disabled people. We need improved access to disability expertise in all areas, with very clear pathways to specialist services that are transparent, including for families. We paediatricians need to know the needs and understand the needs in our local population if we're to achieve and evidence equal and the best outcome opportunities for everybody. We can't do any of this alone and need to work as part of robust interagency networks. Achieving the best outcomes means that we need to have great attention to detail to systematically identify all the needs of the child or young person before us. We need to be proactive in our management, not passively monitoring. We need to avoid diagnostic overshadowing, which means just seeing and blaming the disability for everything. Oh, she's too short because she's disabled. Oh, she behaves that way because she's disabled. She might be in pain, or he might have appendicitis, and it's really important that we pick up all of these facets. We need to proactively anticipate and address any barriers to participation if we are to truly achieve the best possible quality of life for everybody. Essential components of paediatric assessment when development is different include competence in accurate clinical assessment. Never be afraid to go and watch an experienced colleague to brush up on particular skills, for example, neurological examination. We need a working knowledge of the range of typical development and behaviour, and have that in mind at all times so we can recognise when things are different. We need accessible records, all available records and reports, and we need an accessible environment and the appropriate equipment to weigh and measure children who are different, and also to conduct any necessary investigations. We always need to know who our network of phone friends are with whom we can access to gain expert advice along the way. So diagnostic assessment in the paediatric disability clinic starts with taking a thorough background history about the medical history, the family history and developmental history, including the level of current functioning of the child or young person. We need to carefully and systematically examine the child, including measurements of height, weight and head circumference. We need observational information quite often from different settings in order to triangulate the information we gain in clinic with other professionals. We then need to think about what investigations might be appropriate, be these general investigations, genetic or other investigations tailored to the individual child or young person. I've developed over the years some background information sheets to underpin medical, developmental and family history taking. These are freely available from the website of the British Academy of Childhood Disability, and I commend them to you for personal use and for your teams and for use in teaching and training. As well as knowing what's typical or not, we need to have in mind some lines in the sand, some developmental red flags that make us need to refer on for further expert assessment. These would include any loss of developmental skills at any age. Head circumference really matters, and if heads are too big or too small or crossing percentiles up or down, this may reflect changes in what is going on in the brain, because head growth in children in particular, and particularly in infants, reflects brain growth. If there are any concerns about vision, we need an expert paediatric assessment of the child holistically, as well as simultaneous referral to ophthalmology. Similarly, if there are concerns about hearing, we need to draw on the expertise of our colleagues in audiology and ENT, as well as making a paediatric assessment and thinking about appropriate investigations. Any child with no speech by 18 months requires a paediatric disability expert assessment and an urgent hearing test. Hearing can change over time, so it's important to pick up those with progressive conditions. Any child unable to point, to share interest with other children or with others at all by the age of 2 needs further expert assessment to see if their difficulties are generalised, part of a learning disability, or whether they are specific, for example, a red flag for an autism condition. There are some specific evidence-based motor red flags that we need to be mindful of. Any infant who holds their hand fisted after 4 months needs an expert assessment, as does any child unable to hold an object placed in their hands by 5 months. Any infant showing hand preference before 12 months, we need to consider whether the other side has a hemiplegia, and that requires expert assessment. If families experience that their infant has stiff or tight legs when they're changing their nappy and they're 6 to 12 months old, that might be indicative of spasticity and requires further expert assessment. Obviously, there's a range at which children learn to sit, but any children and infants not sitting unsupported by 9 months really do warrant further expert assessment with expert disability eyes. Any boys not walking by 18 months, we need to be concerned about the possibility of Duchenne muscular dystrophy and do a creatinine kinase level. And for girls, we're a little more relaxed and the cut-off is 2 years to think about that. We need to have in mind the definition of learning disability. Learning disability is the term that families prefer, and also it's common in primary care and general practice, where they offer learning disability health checks for those over 14 years of age. Here I'm using learning disability as synonymous with the new ICD-11 definition of disorders of intellectual development. These are described in ICD-11 as a group of etiologically diverse conditions, meaning they have different causes. They start in the developmental period, i.e. in childhood, and they're characterised by significantly below average intellectual functioning and difficulties with adaptive behaviour, which means daily living skills. Cognitive functioning and adaptive behaviour need to be at 2 or more standard deviations below the mean, and in percentile terms this is less than 2.3 percentile. Identification of a learning disability really does matter. The confidential inquiry into premature deaths of people with a learning disability explained how women and men identified with a learning disability are likely to die significantly earlier than those without. The Death by Indifference report, coordinated by MENCAP back in 2006, is heartening reading, telling the lives of 6 people who needlessly died because the signs and symptoms of straightforward things like pneumonia, constipation and appendicitis weren't correctly identified. Identification of learning disability matters because it sets appropriate expectations for the future for the child and family. Instead of setting up the child to always be failing and falling short, it allows the family to celebrate their achievements within an appropriate framework of understanding. Giving learning disability its name encourages reasonable adjustments to improve access to services and participation in everyday activities for everybody. Identification of learning disability encourages proactive health surveillance for the associated conditions that are known to exist, so that we really can achieve the best possible outcomes at reducing that morbidity and mortality as much as is possible. Giving learning disability its name informs access to the GP Learning Disability Annual Health Check system from 14 years and onwards, and also the annual flu immunisation to prevent the respiratory infections and problems which are known to be more common in those with a learning disability. Identification of learning disability is a prerequisite for access to specialist support in social care, including on transition to adult services. If a young person transitions on from school with just learning difficulty on their list of concerns, they're not going to be able to access those specialist learning disability support services, and this is important. So how do we go about assessing cognition? Well, in the clinic, I use an eclectic assessment against what I know and have built up my experience of over the years of what is the broadly typical range for each age. We could use a validated screening tool to help us flag up if learning disability is a possibility, such as that available in the www.learningdisabilitymatters.co.uk resources, which I commend to you. More formal assessment includes a psychologist, usually an education psychologist, unless you're lucky enough to have access to a clinical or neuropsychologist. Psychologists have a range of standardised tools that they can draw on to most accurately assess the cognition of children and young people with a range of needs. So what's the role of the paediatrician in identification of learning disability? First of all, the paediatrician needs to be an advocate to enable those appropriate assessments to be undertaken and to be a prompt for these to be done in education or with a psychologist. The paediatrician needs to train themselves to be able to interpret the reports of colleagues in education and psychology to be able to give learning disability its name. The paediatrician then needs to communicate when a learning disability has been identified, including to the general practitioner, so that appropriate services can be accessed. So how does a paediatrician interpret reports of education and psychology colleagues? It's beholden on us paediatricians to become familiar with the terminologies used in others' reports and the structure of our local reports, which involves having a conversation with our local colleagues. We need to be on the lookout for any IQ scores and or percentiles that are within reports to add evidence to where a child or young person's learning abilities lie. We need to look out for information in others' reports about daily living abilities, such as ability to do shoelaces or self-care. If in doubt, we should never be ashamed to discuss with colleagues, which can be really productive in reaching a decision. I would urge you all to be confident to identify a learning disability in children and young people attending special schools because their primary need has been identified in the domain of learning. Any child or young person with an education, health and care plan or equivalent in the other devolved nations that makes explicit that a learning disability is present, again, be confident. Some children and young people with specific diagnoses such as Down syndrome virtually always have a learning disability, so be confident about that group. And where there's clear evidence in reports from education and or psychology colleagues that cognitive abilities and overall functioning in everyday activities are in the learning disability range, please be confident and give learning disability its name. I would urge a little more caution in the identification of learning disability in children and young people with autism spectrum conditions, particularly in their early years when communication abilities might not be clear. There's a strong association between learning disability and autism spectrum conditions, so of course it's important to identify when learning disability does coexist, but sometimes it's just best to watch and review. Children under 4 years of age, it's not possible to conduct those formal cognitive assessments, and the profiles of these children can change over time with improvement out of the learning disability range. So again, it's best to wait and review. I would also urge caution where reports evidence variation between verbal and non-verbal abilities, because it may be that the learning needs of the child or young person are specific rather than generalised, and that does not equate to a learning disability. So when we're thinking about the developmental journeys of children and young people, we need to be mindful that all children and young people acquire new skills over the passage of time unless they're in the group with conditions associated with loss of skills or stasis of skills. So children with a learning disability might have an IQ below 70, and if it's a more significant learning disability below 50 or profound below 20, they still might continue to acquire new skills over time, and it's important for families to be aware of this. For some children and young people, they continue to acquire new skills but then have an acute brain injury. Along comes a number 13 bus and puts them in paediatric intensive care, and their level of function drops right down to a very low level indeed. And thereafter there's a range of recovery with rehabilitation, sometimes back to within the typical range for age, sometimes not quite to that level, and sometimes, sadly, there isn't any improvement or even death as an outcome. It's always important to be mindful of the possibility of neurodegenerative conditions. Whereas in adults, the onset of these is fairly obvious because skill loss is evident immediately. In children and young people, the trajectories are different because they're superimposed upon that graph of ongoing skill acquisition with age. So the first thing that might occur is a slowing of new skill acquisition, and this might be best picked up in school or by a psychologist. Different neurodegenerative conditions have different trajectories with different peaks and different rates of loss of skills. The line at the bottom is particularly tricky to identify correctly because infants don't acquire many developmental skills in the first place, so working out that there's a loss of skills can be challenging. So we need to be mindful of this group. Having considered our assessment, we then need to come to some sort of differential diagnosis or formulation to understand what's going on. This is very much more often a process than an event, and it may take months or even years. We need to be alert for those diagnostic handles, and remember there might not be a test for a condition such as autism spectrum or attention deficit hyperactivity disorder. And throughout this process of assessment, we need to keep the child and family engaged. We also need to treat the treatable at every single step and to continue to manage associated medical conditions and needs, as well as to advocate for the child and family. So what are these wider needs? What else might be going on? Well, wider needs are really very many and varied across a range of domains, and it may be one or another at each different time that is causing the most challenges for the child or young person, leading to pain or leading to limitation of activities and participation. So the correct identification of each and every need is required whilst we're thinking about what the underlying diagnosis or condition might be. There may also be family reported issues and technology dependencies. There may be difficulties at school. There may be issues within the family with more than one disabled child or other family member with additional needs. There may be housing issues that might benefit from a letter of advocacy from the paediatrician. And then a range of technology dependencies might be in place with tubes and equipment. The child or young person might have a different communication method that requires input from a specialist speech and language therapist to understand it best. Or the child or young person might have a need for round-the-clock care. All of these facets are really important to identify when we're thinking about providing the best level of holistic support. So again, I'm quite keen on tools to assist the capture of complexity of need at any review consultation in the paediatric clinic. This traffic light tool fits neatly on two sides of paper. The first box at the top starts celebrating what's going well, because otherwise the disability clinic can become a long list of everything the child or young person can't do, which can be disempowering. The next box allows the family to think about what might make their life easier or better, or joining in easier or better, so problem solving for themselves. Then there's space at the bottom for concerns and questions. On the reverse, traffic light style, the family indicate for a range of physical health conditions that are known to occur across a range of primary diagnoses and conditions, a range of areas of functioning, and then a range of family reported issues. No concerns is obvious, there aren't any. Some concerns mean that they're there from time to time, and serious concerns means they're really there every day and are really problematic. So this tool is completed in the waiting room before coming into a paediatric consultation and allows focus to be on the things that matter most to the family that day, to make sure that the plan includes addressing at least all of the serious ones, even if there's not time to cover everything. When it comes on to investigations, I now have a set of investigations that I mostly do all the time. I do a blood count and ferritin because iron deficiency is treatable, and that might be helpful for the child. I think it's really important to understand that kidney, liver and thyroid function are normal again, because there may be treatment opportunities, and if we're going to be using any medicines, it's important to know that everything's working properly and that medicines can be handled. Bone chemistry and vitamin D levels also really important. The child with aches and pains might be vitamin D deficient, and we certainly see a lot of this in the north of England where we don't get enough sunshine. Creatine kinase, always important to identify those with neuromuscular conditions promptly, and I include that in my general screen. Chromosomal and genetic anomalies are increasingly common. In our recent review, we were picking up between 10 and 20% of the population coming as new patients into the disability clinic with variations in their chromosomes. We're probably doing less Fragile X tests now that microarray technology is available, because there are other variants that are more common. Any other tests are very much tailored to the individual after careful thought, and if necessary, phoning a friend for some expert advice. When it comes to investigations, there isn't a single list that's comprehensive and appropriate for every child. We do need to tailor after careful thought and formulation. I think genetics is a burgeoning field, and gene panels are more widely available, for example, for the microcephalies or for aspects of learning and epilepsies, etc. Exome sequencing is just around the corner, and I think these are going to become frontline investigations that are then going to prevent us needing to go on with lots of other painful tests. There is no such thing as a metabolic screen is a mantra that was given to me by one of my great teachers, Professor Robert Surtees, sadly no longer with us. Robert always felt that if there were red flags for a metabolic screen, you should continue investigations, preferably in consultation with an expert in paediatric metabolic medicine. Neuroimaging can be really helpful, but it's important also to check who's reporting the scan to make sure that you're getting the most possible out of it. Good old-fashioned looking things up in books, looking up things on the internet, in journals, going to conferences. These are all ways that we can improve our knowledge and help with our diagnostic formulations. If in doubt, never be afraid to tap into the expertise of other colleagues. When it comes to thinking about advocacy for families and positive attitudinal and environmental change, I commend to you the resources within Disability Matters. These are all freely available and have been co-produced with disabled children, parent carers and other experts. There are very many sessions taking between 20 and 30 minutes each that can be completed that give a real insight into the adjustments that can quite easily be made, often without additional cost, to better support disabled children, young people and their families. So in this presentation, I hope I've been able to persuade you that where paediatric assessment is required and children have different developmental journeys, a structured approach can be helpful in clinical assessment and networking with expert colleagues. It's really important to maintain that breadth of vision to pick up each and every need. Proactive identification and management of multifaceted needs really matters. Again, we need great attention to detail to make sure that we've covered all the bases and picked everything up and treated the treatable. We need to be ever mindful to avoid diagnostic overshadowing. We need to respect and include all who are physically and/or developmentally different. Meaningful inclusion with kindness really does matter and makes a positive difference. Proactive identification of any barriers to inclusion and participation can really improve the quality of life of children, young people and their families. We as paediatricians can help with advocacy, which really matters for families. Thank you very much for listening.